Good morning, and it's a real pleasure to be here among my friends, and especially one of the chairperson is Dr. Rini. I'm seeing after a long time. She was my college mate. We both belong to Medical College Kottayam. So I'll be dealing with beyond the numbers, tailoring LDL targets for optimal cardiovascular risk reduction. It's not the LDL, not the VLDL. What we are attacking is the atherosclerosis. Now the concept is changing. Rather than treating the atherosclerosis, if possible, we have to try preventing atherosclerosis. Right now, it's an impossible task. This results from the ApoB containing lipoproteins retention in the vessel wall. It penetrates the intima, get inside the intima, and develop this thing, atherosclerotic plaque, with its various morphological features, including a lipid core, thin fibrous caps, and the trajectory of the atherosclerotic this plaque. It may remain stable, it may progress, lead on to chronic stable angina, and at times in the life history of a person, the fibrous cap may rupture, leading on to acute coronary syndrome. So if you look into the various studies so far, the Mendelian randomization studies, prospective cohort studies, and randomized control studies, we have a robust amount of data with large number of patients, which has proved beyond doubt that if you reduce LDL cholesterol, it produces a proportionate reduction in the risk of coronary artery heart disease. And the magnitude of the reduction, or rather the magnitude of the exposure to the lower LDL cholesterol to the arterial wall, it determines the benefits of reduction in LDL cholesterol, and it is proportionate to the reduction in the LDL cholesterol level. This is the apoprotein B containing lipoprotein family, which is considered the atherogenic lipoproteins, the LDL cholesterol, the lipoprotein A, and the remnant lipoproteins, ideal and very low density lipoprotein. And all the studies which I have shown you, the observational epidemiological data, the Mendelian randomization, and the genetic analysis, randomized controlled trials including, and the animal experiment, all these have converged into a single point so far, that LDL cholesterol as the causal agent. And that's why LDL cholesterol is still the primary target, and lower LDL cholesterol is what we desire for. And now the stress is on maintaining an optimal lipid levels throughout the life for a primary prevention, secondary prevention, and a legacy effect. So when you look at the evolution of the lipid lowering therapies, we have statins, the oral combination of statins with ezetimibe, icosapentaene, bempedoic acid, or fibrate, which is a daily affair, or bi-monthly or monthly use of a monoclonal antibody against the PCSK9, or antisense oligonucleotide, which can be used weekly or monthly, or a small interfering RNA, which once in 6 months. And now we are into vaccination of gene editing, which is a lifelong therapy. Give an injection or give a therapy for a lifelong low LDL cholesterol level, and LDL is still the main target. So the drugs with the cardiovascular outcome trial, statins, ezetimibe, PCSK9 inhibitor, and fibrates, icosapentaene. So for LDL cholesterol, we have the statins, ezetimibe, PCSK9 inhibitor. These are the currently evidence-based therapy, including some evidence for bempedoic acid, inclisiran, evinacumab. So if you look at, this is data from the NHS, 90% of the cardiovascular disease were treated with statins. We prevent 14,000 heart attacks, strokes, and deaths in 3 years. If the treatment rate can be increased to 95%, another 22,000 events would be prevented. So the English data says, as of March 2023, 83% of the patients with recorded CVD are currently being treated with lipid lowering therapy. But worldwide data, what it shows is hardly 20 to 30% of the patients reaches their LDL goal. These are the available gadgets for us. In a statin tolerant person, For a 60% reduction, we can either use a 20 to 40 milligram of rosuvastatin plus ezetimibe, or a 40 to 80 milligram of atorvastatin plus ezetimibe, or a 5 to 10 milligram of rosuvastatin plus alirocumab or evolocumab, or double dose, that is 10 to 20 milligram of atorvastatin plus the PCSK9 inhibitor, or inclisiran plus 5 to 10 milligram of rosuvastatin, or 10 to 20 milligram of atorvastatin plus inclisiran, or the oral triple combination, which can produce almost close to 65% reduction in the LDL cholesterol, that the high intensity statin, 40 milligram of rosuvastatin or 80 milligram of atorvastatin plus ezetimibe plus bempedoic acid. And for a 80% reduction in the LDL cholesterol, we require the highest intensity statin, 40 milligram rosuvastatin plus ezetimibe plus the PCSK9 inhibitor, or 40 to 80 milligram of atorvastatin plus PCSK9 inhibitor and ezetimibe, or inclisiran plus a higher dose of rosuvastatin, 20 to 40 milligram, or inclisiran plus 40 to 80 milligram of atorvastatin. This is in the statin tolerant patients. And for a statin intolerance, you get a 35% reduction with ezetimibe and the bile acid. We don't use the bile acid sequestrant. So basically it is bempedoic acid and ezetimibe for us, which produces close to 30 to 35% reduction. And if we add with these two drugs, if we add a PCSK9 inhibitor or inclisiran, we can get a 60% reduction. So even for statin intolerant patient, it is possible to get a 60% or 65% reduction in the LDL cholesterol with the use of triple therapy, 1 injection and 2 oral drugs. So if you look at the age, the LDL modification and the cardiovascular events, the dotted lines, you can see the dotted lines, the lowermost portion, that is the lifelong lowest LDL level. So this shows the lifetime low LDL level when the event rate is so low. And if you look at 30 years, 40 years, 50 years and 60 years, the age at which you are going for a 50% lowering of the LDL, can see the benefit. So at 60 years, the benefit is lesser than at 40 years and the benefit is lesser than at 30 years, and the maximum benefit if you have a lifetime low LDL level. So that's why now the concept is not only lowering the LDL cholesterol, you lower the LDL cholesterol at the earliest, and the system should be exposed to the low LDL level for the longest period of time. The relationship between the baseline LDL, magnitude of reduction, exposure time and benefit. You can see more the LDL cholesterol, more the absolute reduction. If you start at a higher level of LDL cholesterol, you start your therapy to lower it, you get a more benefit. And more the duration of therapy, more the benefit. So now it is intensive therapy, more exposure time to derive the maximum benefit. And if you add the CVD risk, the entire CVD risk also to this, the CVD risk, LDL level, magnitude of LDL reduction and benefit, you can see all these things are related. Higher the CVD risk, higher the baseline LDL level, more intense reduction in the LDL and more prolonged reduction in the LDL level, the benefit is more. So absolute atherosclerotic cardiovascular reduction in lipid modification depends, or it's based on baseline atherosclerotic cardiovascular disease risk, baseline LDL level, absolute magnitude of LDL reduction and the duration of therapy. So it's not for a short period of time, it's a long plan. And the risk stratification is important. The very high risk is patient with atherosclerotic cardiovascular disease, either clinical or imaging based. And a high risk score, European Society use the SCORE risk score, or a familial hypercholesterolemia with atherosclerotic cardiovascular disease or other major cardiovascular risk factor, severe CKD with eGFR of less than 30, diabetes with more than 3 major risk factors, or a target organ damage, or type 1 diabetes of more than 20 years duration. And the high risk is SCORE risk of 5 to 10%, or a markedly elevated single risk factor like a total cholesterol of more than 310, LDL of more than 190, or a blood pressure of more than 180 over 110 millimeters of mercury. familial hypercholesterolemia, no other risk factors, CKD, eGFR 30 to 59, or diabetes mellitus without target organ damage, or duration of more than 10 years, no other risk factors. So in a very high risk, the target of LDL cholesterol is 60% reduction from the baseline, and number is 55 milligram per deciliter, and corresponding ApoB is less than 65, non-HDL cholesterol is less than 85. High risk, it is 70 or 50% reduction. For ApoB, it is 80, and non-HDL cholesterol, it is 100. And moderate risk, it is 50% reduction. The number of, the absolute value is 100 milligram per deciliter of LDL cholesterol. ApoB is 100 milligram, and non-HDL cholesterol is 30 above, that is 130 milligram per deciliter. And for a population, it's always better to keep their LDL cholesterol below 150 milligram per deciliter. And the efficacy and safety of achieving very low LDL cholesterol, because many times your patients will be coming to you telling that, sir, my LDL cholesterol is less than 40, it is 35, it is 20. What should I do? Is it dangerous? The Fourier analysis data, they have shown that the significant number of patients with LDL cholesterol less than 10 milligram per deciliter, no safety signal, no safety issue. But at the same time, the benefit was preserved. So there is a monotonic relationship between the achieved LDL cholesterol and the major cardiovascular outcomes down to an LDL cholesterol of less than 10 milligram per deciliter. And conversely, there was no safety concern with even very low LDL cholesterol over a median of 2.2 years. So this data support that further LDL cholesterol lowering in patients with cardiovascular disease to well below the current recommendation. So lower is totally better regarding LDL cholesterol. And we have to worry only about one thing, the high LDL cholesterol, not about the low LDL cholesterol. I'll discuss only one study, which is the recent one, that is a Pacman AMI study. Patients with NSTEMI or STEMI undergoing coronary angiography and successful PCA of the infarct vessel and two non-infarct related arteries with non-obstructive lesion. And they serially evaluated with intravascular ultrasound to look at the atherosclerotic plaque burden along with NIRS and the OCT to see what is the regression level of atherosclerosis, or is there a progression of atherosclerotic burden in these patients who are again treated with alirocumab 150 milligram biweekly plus rosuvastatin, which was initiated less than 24 hours after PCA, versus rosuvastatin 20 milligram with placebo. So the change in LDL cholesterol at 4 weeks with alirocumab, it's close to 24 milligram per deciliter. And in the patients who are put on only rosuvastatin, it was 74 milligram per deciliter, and they started with a mean LDL cholesterol of 130 milligram per deciliter. So majority of the patient has already reached their target level or well below their target level at 4 weeks with the alirocumab. And this is the percentage change in the atheroma volume. The regression of atheroma is much better with all the modalities. They found that with the aggressive lipid lowering using alirocumab, there is a significant regression of atheroma over a period of 1 year. So it means the relevance is in patients with acute MI, the addition of subcutaneous biweekly alirocumab compared with placebo to high intensity statin therapy resulted in a greater coronary plaque regression in non-infarct related arteries after 52 weeks. We need further research to understand whether this improves clinical outcomes, because this is only showing regression. They didn't look at the clinical outcome. The Asian or the Indian phenotype with higher CRP, more insulin resistance, greater abdominal adiposity, lower level of adiponectin, characteristic dyslipidemias like high triglyceride, low HDL, high small dense LDL, and increased susceptibility to type 2 diabetes and CAD. Their recommendation, we cannot extrapolate the recommendations by Europeans or Americans to us. So the Lipid Association of India, they have a particular category called the extremely high risk category with an LDL cholesterol target of less than 50 and an optional goal of less than 30, and LDL goal of less than 30 in the category B, which is extremely high risk. That means CAD, established CAD with additional risk factors, mostly diabetic, other vascular disease involvement like the polyvascular disease, stroke or peripheral arterial disease, multiple risk factors, or a recurrent ACS. There, the combination lipid therapy is considered to be the first line therapy Assess the risk, extremely high risk, straight away start on statin plus ezetimibe. If the reduction is less than 50% or the LDL cholesterol is more than the 55 milligram per deciliter, add PCSK9 inhibitor. An extremely high risk patient, statin plus ezetimibe plus PCSK9 inhibitor, or even in inclisiran. This is a thought-provoking, and I'll say it is little provocative measurement, but this is going to be the future. So intensive lipid lowering rather than intensive statin therapy, efficient reduction LDL without delays. So atherosclerosis results from retention of ApoB contains lipoproteins in the vessel wall. Individuals have differential retention of lipoproteins and hence differential vulnerability to the exposure of LDL. So it is not LDL or ApoB in isolation is sufficient. Most cardiovascular events occur in those without extreme LDL elevations. And atherosclerotic cardiovascular disease can be reduced by reduction in LDL cholesterol through multiple differential pathways. Benefit is proportional to the magnitude and duration of reduction. And it is the cumulative LDL arterial burden which is the central determinant. Lower the LDL cholesterol level at time by agents that primarily target LDL receptors, greater the clinical benefit. Relative risk reduction and absolute risk reduction related to the magnitude of LDL cholesterol reduction, and high cardiovascular risk, aggressive, early reduction. So there are successes, surprises, and future challenges in prevention of atherosclerosis. And it's a life course health development. And this is philosophy of lowest LDL for the longest life period, starting at the earliest. And the ultimate goal is optimal life course health. And goal or outcome is what matters. It doesn't matter how we get there. Priority is to preserve health rather than to treat disease. Thank you so much.
We should be starting combination therapy right from the beginning in most of the patients. I think that is a possible lesson that we have learned over the years.
Absolutely, sir. I think we are changing. The concept is changing. It is quite early. We should not expose the person to high LDL level for a longer period of time and allow time to the atherosclerosis to set in. We should prevent the development of atherosclerosis, which requires an early therapy. So early aggressive therapy is the rule rather than the lowest LDL cholesterol. It is early, aggressive, lowest LDL cholesterol for the longest period of time.